From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about the risk factors for lung cancer and the importance of lung cancer screenings. Our guest today is Amy Miller, a nurse practitioner at the Brian D. Jellison Cancer Institute. She also coordinates the lung cancer screening program at Sarasota Memorial. Amy, thank you so much for being with us.
Thanks for having me. It's awesome to be here.
Let's just start with the basic of what is lung cancer screening and what tests are run.
Yeah, so lung cancer screening, I like to tell people that it's relatively new and it's sort of in its infancy still, right? So really the Centers for Medicare and Medicaid Services only approved payment for it in 2016. So we're only talking really a handful of years that lung cancer screening has sort of been out there. Lung cancer screening is intended for people who are high risk for getting lung cancer. So it's a very specific population of people. The United States Preventive Service Task Force says you have to be between the ages of 50 and 80, although CMS says 77. So I don't like that they don't have the same guidelines, but that's sort of what we have to go with. Be either a current person who's currently smoking or someone who formerly smoked and quit within the past 15 years and then smoked for 20 years or more. So those are the population of people who are really eligible that are considered high risk for getting lung cancer. So we want you coming in and getting a screening exam on an annual basis. It's actually a CAT scan. It's a low-dose CAT scan. It's done under a low-dose protocol, so the amount of radiation that you're exposed to is much less. It's about 90% less than a regular CAT scan. It's about the same amount of radiation that you would get from a mammogram. So again, it's really about early detection and finding if there's anything out of the ordinary going on in somebody's lungs, finding it as early as possible so that we can do something about it.
Now, how do you help people determine if they should be screened? I mean, I know you gave those guidelines, but someone might say, oh, technically I smoked for 5 years and then didn't for 2. How do you help them determine if they're someone who should be screened?
Yeah, so that's in general one sort of complicating factor about lung cancer screening in general is understanding what your pack year history is. So basically sort of, to make it easy, you take the packs per day, the average packs per day that you smoked, and multiply it times the years that you smoked. So if you smoked 1 pack a day for 30 years, you have a 30 pack year history. But smoking isn't really like that, right? Because you start, you stop. When you started, maybe you were smoking a half a pack, maybe you got up to a pack and a half. And so really kind of understanding that pack year history is a little more challenging to figure out. And that's actually one of the barriers that we have with lung screening is understanding how do we calculate a pack year history. So I go into a lot of detail with people, asking them, when did you start smoking? When did you stop? Did you ever have any periods during that you didn't smoke? And on average, how many packs per day did you smoke during the years that you did smoke? So it is a conversation that kind of goes into a lot of detail, but I think it's really important to really understand that risk status.
How can people evaluate their risk? Of course, the recommendation is always smoking cessation completely. However, if someone's maybe tapered off their smoking, but still has the occasional cigarette when they're stressed or when they feel they need to, how do you help them determine you got to get in here or you don't?
So the official definition of someone who's a current smoker is anybody who's had 1 cigarette, even a single puff in the last 30 days. So that's how I define when I'm really trying to tease that out a little bit. So even if somebody is only smoking occasionally, once a month, once every other week, socially, during happy hour, or different things like you suggested, then they are considered someone who's currently smoking.
How often does someone have to be screened if they?
Annually.
Okay.
Annually. And I always say the endpoints, and this is one of the things in my job, I say this over and over and over again every day because it's so important. Really, adherence to annual screening is key. That's how we're going to determine if any lung nodules that you may have are changing, that they may be considered more malignant. And so really staying adherent to your annual screenings is absolutely vital. And so we work really hard. I work really hard in making sure that every day when I talk to people about lung screening that they understand this is not a one and done scan. This is a process and it's something that you're going to have done every year.
Do you think that's maybe part of the reason that people who would have access to lung cancer screening or should be screened don't?
I don't really think that actually, because women come in and get their mammograms done every year, right? I mean, it's something that's ingrained in you. You know that at 40, you start getting a mammogram and you have one done every year. It's just part of your sort of, annual wellness checks. So I think that really the barriers related to lung cancer screening are different than that.
Why don't people get screened then?
So, it's really sad. In the US, there are like 14.2 million people who are eligible for annual low-dose CT lung screening, right? But only about 5% of those people are getting screened. It's really tragic because we have a life-saving scan. So really what we are, when we look at sort of the barriers, like I talked about mammography, so it's pretty simple, right? You're a woman, you're 40, you start having scans. Everybody knows that. It's been going on for decades now, right? So lung cancer screening is still really in its infancy. There are other complicating factors. You have to understand if you meet the eligibility criteria, right? So there's those things that I talked about. And then also too, there's typically an insurance authorization required, because unlike a mammogram, all you need to know is that you're a woman over the age of 40. Yeah, you're going to get your mammogram. But with a lung cancer screening, it's a little more detailed. So the insurance companies want to make sure that you are meeting that eligibility criteria. So you have to relay that to them. So that can be a barrier sometimes as well. I think, the idea of false positives kind of worries people a little bit too. And that's when we find a nodule and then maybe over further testing, we find out that it's not cancer, right? So lung cancer screening has been criticized as having a high false positive rate, but I can assure you that here at Sarasota Memorial Hospital, we are very thoughtful about the recommendations that we make for anybody with any sort of indeterminate nodules. We are not going to put people through biopsies or bronchoscopies or surgeries unless we're sure this is cancer, right? So that's one barrier. But I think the biggest barrier when it comes to lung cancer screening is it's attached to the stigma of smoking. And I think that that's the biggest issue.
Now, you discussed smokers and how they are able to qualify for this screening.
Yep, absolutely.
But what about people who are exposed to secondhand smoke? Those who maybe live with a smoker who does smoke in the home.
Right.
Should they be screened as well?
So the science does not support that. So that's that's a good question. People come to me all the time. So when the National Lung Screening Trial was being done, they looked at 50,000 people, and they had very certain eligibility criteria. Basically, being someone who smokes, quit within the past 15 years, smoked for 30 years or more, and that age range. So that's what the science supports for screening criteria. Now we know that actually radon exposure is the second most common cause of lung cancer, right? But it's not included in any eligibility criteria. And a lot of us don't know if we were ever exposed to radon. But things like secondhand smoke or occupational exposures or different things like that, family history of lung cancer. So none of those things really make people eligible for lung cancer screening, unfortunately. However, there are always people working to try to expand the criteria because we know that people who've never smoked still get lung cancer. I always say, if you have lungs, you can get lung cancer. So we are working to expand those criteria.
Now, is vaping included in the smoking?
So it's not, vaping is still really new. We don't really know what the long-term effects are related to vaping. But some information is emerging, which is a great thing. We know it's bad for you, right? There's no question. You're actually, heating a substance and inhaling it into your lungs. And there are cancer-causing agents in some of those substances. So we know that, that it will, down the road, we will see sort of longer-term effects related to vaping. So, but right now, it does not qualify you for lung cancer screening.
So it sounds like because the screening is still in its infancy, who qualifies may expand in future as we see more science come.
Yeah, for sure. There's no question about that. And especially like we're understanding more about the biology of lung cancer. So, people who may have some sort of mutation or at higher risk for that. Because we know that, like, for instance, younger Asian women have a higher risk incidence of lung cancer. So how do we get those women screened, right? So that's one of the things that they're looking at.
Can you discuss any risks of lung cancer screening? Because it is a CT scan.
Mm-hmm. Right, yeah, for sure. So, a lot of people are sort of blasé about it. It's just a CAT scan. There's no IV contrast or whatever. But it's very important to understand what the risks are related to lung cancer screening. So you are exposed to a certain amount of radiation. It's not huge. And people will say to me things like, well, is it worth it to get the lung screening to be exposed to that radiation? And my answer is always, it's really your choice. You have to make that decision. I will tell you, I will educate you, and then ultimately you make the choice. But basically, what I tell people is that your risk of getting lung cancer, if you meet that high risk criteria, is way more serious than the risk of any sort of small amount of radiation. So for sure, get your lung cancer screenings if you're high risk.
Even if they have to do it annually, it's still...
Yeah, and so that's why we have a low dose protocol. So, the radiology team here is fantastic. Early on in the day, they wrote protocols that the technologists actually follow to be able to deliver the very lowest dose of radiation to still get a very good picture of your lungs. So yes.
And can you talk about the lung cancer screening programs at SMH specifically, how it works, how people come in? If someone is listening or seeing this podcast and says, I meet those criteria.
Right.
What are their steps?
Yeah, that's a great question. So the first step is to always talk to your doctor about it, right? So again, we want to have what's called a shared decision-making visit, so a conversation about lung cancer screening. And we didn't really talk more about the risks, but when you have a low-dose CT, sometimes it can open up the door for other things. Like if you have a nodule that's found, well, then you're going to maybe have to have a biopsy. So there's risks involved with that: bleeding, infection. You could have a collapsed lung, those sorts of things. So really important to have a conversation with a healthcare provider about lung cancer screening, whether it's your doctor or myself or somebody that can really provide that information for you. So after you've decided that, yes, this is still for me, I want to proceed, then the next step is to get an actual order from your doctor, with the right codes on it, the right diagnosis codes, things like that. And then just call our scheduling line and say, I'm calling to schedule a low dose CT scan at Sarasota Memorial. We currently are screening at 5 locations. So Heritage Harbor, here at Main Campus, our IFAM at Clark Road, Northport, and Blackburn Point, and hopefully soon the new Venice Hospital campus as well. So multiple times for people to be able to come in and get their CAT scan done.
Why do you think it's so important that SMH has this program and has so many locations that provide these screenings?
Well, make no mistake, lung cancer, #1 cause of cancer death, right? It kills more people than prostate, colon, and breast cancer put together. So it's sort of perplexing to me that, not more attention is paid to lung cancer, right? It's the #1 cause of cancer death. More women die from lung cancer than they do breast cancer, right? More women are diagnosed with breast cancer, but they're surviving, and it's all because of mammography and early detection. So if we can do the same thing with lung cancer, we're going to change those numbers. We're going to shift the stages. So right now, most lung cancer is found at stage 4, late stage. People are already symptomatic, they're coughing up blood, they're losing weight. And at that point, there's really not a lot that can be done. I mean, it's a terminal illness at that point. Certainly, there's a lot of treatments out there that can extend people's lives. We've made huge leaps and bounds forward with that. But really, finding a cancer at the earliest stage is key to really help people live a normal, healthy remainder of their life. So you find a lung cancer at a stage 1, they have a surgical resection, and then basically they walk away from their surgery being cured from lung cancer. So that's really remarkable. So lung cancer, make no mistake, is the most immediate intervention that we can employ to reduce the mortality related to lung cancer, which is huge. So that's why I just feel very strongly about, really, just making people aware. I had an event this past weekend where we were screening some Sarasota County school employees, and overwhelmingly, when I was walking back with people, the comment that I heard was, "I had no idea the screening existed." So right, so it's mind-boggling that here we are, already many years into really lung screening, 7 or 8 years, and people are still making comments like that. So we just really have to make the awareness out there. Really pushing primary care doctors to say, hey, are you assessing your patients for their risk? Are you ordering the scan? What can I do to help you? That kind of thing.
So you're part of the team at the Brian D. Jellison Cancer Institute. And while many people who get screened don't have lung cancer, for those who do, can you talk about the importance of having all under one proverbial roof, everything from testing to diagnostics to treatment?
Right.
and all of that working together at the Jellison Cancer Institute.
Yeah, we have an amazing team of people. One huge benefit that we have in our cancer center is our tumor boards. So it's an opportunity for me to bring high-risk nodule scans to the tumor board and have a multidisciplinary conversation. So I basically have a radiation oncologist, a medical oncologist, a radiologist, a pulmonologist. We have all these experts sitting in the same room looking at the scan and making very clear recommendations about what the next step best is for this patient. And then from there, I can actually easily refer to pulmonology or thoracic surgery. And so the main importance of all of that is really timeliness to care. Right, so you have cancer, you don't want to wait 6 weeks to see the surgeon or the pulmonologist to have your bronchoscopy or the interventional radiologist to have your biopsy. So the nice thing about working with these teams is that you can really, streamline and get patients in and seen very quickly. Sometimes, it could be the difference between a stage 2 and a stage 3, right? That's huge when you're talking about staging in cancer. So really timeliness to care, getting people in as quickly as possible and getting their diagnosis and their treatment as quickly as possible is the goal.
Well, Amy, you've told us so much about lung cancer screening today. What's your main message to the community?
So my main message would be, even if you're still smoking, it's fine. Just come and get your lungs scanned, right? We know that this cancer kills so many people and it doesn't have to be. Yes, when you come in, I will talk to you about, what can we do to help you move towards a path of being smoke-free? But that's just part of what I'm supposed to do when it comes to, managing these patients and having these conversations. We obviously at Sarasota Memorial want people to be as healthy as they can be, but coming in, if you're high risk, talking to your doctor about a screening exam and coming in and sticking to your annual screenings until you're no longer eligible anymore is really the most important point, because we don't have to lose so many people to this deadly disease.
Amy Miller, thank you so much for answering all these questions today. And as always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.